Okay, so here is a short overview of hypothyroidism. So hypothyroidism is a disorder that results when the thyroid gland produces an insufficient amount of thyroid hormone. When thyroid hormone production decreases, the thyroid gland enlarges in a compensatory attempt to produce more hormone, and this results in a goiter, and it's usually a simple or a non-toxic form. Most commonly, hypothyroidism can be either primary or secondary. Primary is more common, and it may be caused by congenital defects in the gland, loss of thyroid tissue following treatment with surgery, radiation, antithyroid medications. It can be from thyroiditis, or it can be from an iodine deficiency. Secondary hypothyroidism might result from pituitary thyroid stimulating hormone deficiency, or it could be a peripheral resistance to the thyroid hormone. Tertiary is least common, and this is caused by failure of the hypothalamus to produce thyroid releasing factor. So this results in the pituitary gland not being triggered to release thyroid stimulating hormone, so the thyroid gland itself never gets the message to release the thyroid hormones. Hypothyroidism can occur at any stage of life. It's most common in women between the ages of 30 and 60, and the incidence rises after 50. However, it can happen to young infants and children. So cretinism is a state of severe hypothyroid that's found in infants. It is a congenital state that is usually due to maternal hypothyroidism. Cretinism can be divided into two types, but they both have considerable clinical overlap, and both can be prevented by adequate maternal and childhood iodine intake. Juvenile hypothyroidism. This is the most common disturbance of thyroid function in children. Acquired hypothyroidism is most often caused by autoimmune thyroiditis. As in adults, acquired hypothyroidism can be caused by both thyroid disease or a hypothalamic pituitary disease. The most common manifestation of hypothyroidism in children is declining growth velocity, often resulting in short stature. So the growth delay tends to be insidious in onset, and it might present for several years before any other symptoms occur, if they occur at all. Another common feature is altered school performance. So performance often declines, but in some children it actually improves because the child is less active and less easily distracted. And so one reason for delay in diagnosis is that the parents see these latter changes as positive. Other common symptoms are sluggishness, lethargy, cold intolerance, constipation, dry skin, brittle hair. Um, if the cause is hypothalamic or pituitary, the child can also have headaches, visual symptoms, or manifestations of other pituitary hormone deficiencies. And then the most common physical finding at presentation is that diffusely enlarged thyroid gland, which we call a goiter. In older adults, manifestations of hypothyroidism are often thought to be the result of aging instead of a pathologic process. So they require very careful evaluation of the symptoms to figure out exactly what is going on. So like I said, anyone can develop hypothyroidism. However, it is more common among women older than 50 years, among those who have a close relative with an autoimmune condition, and among those who have had thyroid surgery. They've received radiation to the neck, or they've been treated with an antithyroid medication. Women are affected 7 to 10 times more often than men. Other factors that result in decreased thyroid hormone include iodine deficiency and Hashimoto's thyroiditis. So Hashimoto's thyroiditis is the most common cause of goiter and primary hypothyroidism in both adults and children. So this is an autoimmune disorder in which antibodies develop that destroy the thyroid tissue. So that functional thyroid tissue is replaced with fibrous tissue, and our thyroid hormone levels decrease. But these decreasing levels of thyroid hormone during the early stages of the disease, they prompt the gland to enlarge in an attempt to compensate, which causes a goiter. However, as the disease progresses, the thyroid gland eventually just kind of shrivels up and becomes smaller. Again, this disorder is more common in women, and it has a familial link. Hypothyroidism usually has a slow onset, with manifestations occurring over months or even years. Patients with hypothyroidism, they characteristically have a goiter, they have fluid retention and edema, a decreased appetite, weight gain, constipation, dry skin, dyspnea, pallor, hoarseness, and muscle stiffness. So in general, their metabolism is just slowing way down, and that's what's resulting in all of these symptoms. Many patients also have a decreased sense of taste and smell. You'll see menstrual disorders, anemias, and cardiac enlargement. And the pulse typically is slow as well in patients with hypothyroidism, and sleep apnea is more common. Some other findings that you'll see later on: deficient amounts of thyroid hormone cause abnormalities in lipid metabolism. So we see elevated serum cholesterol and triglyceride levels. As a result of this, the patient is at increased risk for atherosclerosis and cardiac disorders. And then decreased renal blood flow and glomerular filtration rate reduce the kidney's ability to excrete water, which might cause hyponatremia. Because a decrease in thyroid hormone levels will lower the metabolic rate and heat production, hypothyroidism affects literally all of our body systems. Another thing that we see that's a little different is that due to the low metabolic rate, cellular energy is decreased and metabolites build up inside the cells. So this increases the mucus and the water, forming cellular edema and changes in organ texture. This edema is called myxedema because rather than just being caused by water alone, it's caused by water and mucus. So this edema changes the patient's appearance. Non-pitting edema forms everywhere, especially around the eyes, in the hands and feet, and between the shoulder blades. The tongue thickens, and edema forms in the larynx, which also makes the voice husky. And in general, just physiologic function is decreased. Hypothyroidism is diagnosed by the clinical manifestations and by a decrease in thyroid hormones, especially T4. Now, our thyroid stimulating hormone concentration often is increased because the negative hormonal feedback from the thyroid hormone is lost. You're going to see these same laboratory and diagnostic tests used to diagnose hyperthyroidism, although in that case we usually have opposite results. We're going to do some radiologic tests, such as X-ray, CT, MRI. We might be using these as a way to try to identify a lesion or any underlying cause of hypothyroidism. So not everybody will get them, but if we think there's potentially an underlying cause, we'll do these additional tests. We'll also do a radioisotope scan to look at the uptake of iodine by the thyroid gland. With hypothyroidism, we will see decreased uptake. We also want to look at an ECG because dysrhythmias are common. The patient may have decreased cardiac output related to altered heart rate and rhythm as a result of decreased myocardial metabolism. We have to take into account that this disorder affects all organ systems, so it is important to prioritize. Obviously, airway, breathing, and circulation are our main priorities. The patient may have ineffective breathing pattern related to decreased energy, obesity, and fatigue. We want to provide lots of rest periods and increase their activity level very slowly. We need to keep an eye on their oxygen saturation, their breath sounds, and be constantly monitoring for cyanosis. We want to monitor our cardiovascular status closely to maintain a heart rate above 60. We want a blood pressure within normal limits for age, and we don't want to see dysrhythmias, neck vein distension, or peripheral edema. This is a patient who also might be at risk for disturbed thought process related to impaired brain metabolism. So we want to observe for and record the presence and the severity of any lethargy, drowsiness, memory deficit, poor attention span, and difficulty communicating. These problems should decrease with thyroid hormone treatment, and the mental awareness usually returns to baseline levels within about 2 weeks. Other potential problems are imbalanced nutrition, hypothermia, and constipation. So we want to provide meticulous skincare, and we'll probably put the patient on some type of bowel regimen. Patients are often very cold because of the decreased metabolic rate, so we want to be sure to provide blankets and keep the patient warm, but we have to be careful about it. We don't use any other external warming devices like a bear hugger, because what happens when we warm the extremities? They vasodilate, and this increased blood flow to the extremities means less blood flow to our vital organs. So this can actually produce a vascular collapse, which is essentially hypovolemic shock. Patients are also at a risk for disturbed body image. There are a lot of changes to physical appearance, and this can be very difficult for patients. We want to encourage them to verbalize their feelings and their fears about the changes that they see happening in their bodies. And just another note here, because sedating a patient with hypothyroidism can make respiratory difficulties worsen, we want to avoid this if at all possible. This is a patient who is already hypometabolic, and we don't want to give them any medication that might slow them down even more. If necessary, the dosage is reduced because hypothyroidism increases sensitivity to these drugs. The treatment for hypothyroidism is thyroid replacement therapy. Levothyroxine is the treatment of choice, and it is used pretty much exclusively. It is a synthetic hormone that restores adequate hormone levels, and it reverses the signs and symptoms of hypothyroidism. It's taken daily as a pill, and patients usually notice improvement of symptoms after just a week or two. Determining the proper dosage, however, can take time, so the provider should be monitoring TSH levels periodically and adjusting the dose as necessary. The nice thing is, levothyroxine causes virtually no side effects when it's used in appropriate dosage, and it is relatively inexpensive. The main complication that can come along with hypothyroidism is called myxedema coma. So this is a life-threatening complication. It's usually triggered by an acute illness or a trauma. It can also be precipitated by infection, failure to take thyroid replacement medications, use of central nervous system depressants, and exposure to cold temperatures. Though it is rare, myxedema coma most commonly occurs during the winter months in older women with chronic hypothyroidism. It is characterized by severe metabolic disorder, so you might see hyponatremia, hypoglycemia, lactic acidosis. You'll commonly see hypothermia. There might be a shallow edema, especially around the eyes, hands, and feet. It can cause cardiovascular collapse. impaired mentation, and coma. So treatment addresses the precipitating factors and the manifestations. It's going to involve maintaining a patent airway. We are going to maintain fluid balance, usually with normal, like IV normal saline. We are going to check electrolyte status and replace electrolytes as necessary. We want to maintain cardiovascular status, increase their body temperature, and increase their thyroid hormone levels. If untreated, the mortality rate is high, and untreated myxedema coma can lead to shock, organ damage, and death. So again, we'll maintain that patent airway, we'll replace fluids, we are going to give levothyroxine sodium IV as prescribed. We'll probably give some corticosteroids as prescribed. We're going to be checking temperature at least hourly, monitoring blood pressure at least hourly. We want to cover the client with warm blankets, monitor for any changes in mental status, make sure we're turning them every 2 hours to prevent skin breakdown, and we're also going to want to institute aspiration precautions.